female who presented to JNMC.
Today we are going to discuss a patient of obstructive jaundice. Jaundice, in fact, we don't know whether it's obstructive or not. And this lady has come to us and for only in 15 days complaints, and the history will be given by the resident students, and then we will discuss the case.
Mrs. Maksudan is a 65-year-old female from Hathras. She presented to JNMC OPD with complaints of yellowish discoloration of eyes and skin and bloating post meals. History of presenting illness. Patient was apparently well 15 days back when she noticed yellowish discoloration of eyes, which then gradually progressed to all over the body. The yellowish discoloration is also associated with black colored stools. Earlier it was, according to patient, earlier it was very black, but now it is not as black as before, and there is no difficulty in washing away the stools. And there is no complaint of pain abdomen and no history of nausea and vomiting, but there is history of bloating post meals. Patient feels that the food is not digested, and they feel as if complaints of gas in abdomen. And
No, when you have a patient of jaundice, the main complaint is jaundice. पीलिया हो गया, है ना? So you have to first think that what are the possible causes of jaundice. So the possible causes of jaundice will include obstructive and non-obstructive. So for obstructive jaundice, what are the clinical features which you have to ask in the history?
pruritus.
Pruritus. Is there any pruritus? There is no pruritus. There is clay-colored stools? No clay-colored stools. And it is progressive jaundice? Progressive jaundice. So mainly in the history you will get clay-colored stools, itching, and progressive jaundice. That is the typical presentation of an obstructive jaundice. In a non-obstructive jaundice, the jaundice will be mild, usually not associated with pruritus and clay-colored stools. That is only the part of the history. But of course, the other things will be checked in the examination. So, any history of fever?
No.
Fever again is very important. That is usually associated with non-obstructive jaundice, because viral hepatitis, serum hepatitis, all these are associated with fever. So in this case, there is no fever, there is no itching, there is no clay-colored stools. So very unlikely that from the history you can say that it is not a case of non-obstructive jaundice. Now coming to the obstructive jaundice also, we have to see what is the area where the obstruction is there, if at all it is an obstructive jaundice. So before that we like to do a general examination. Has anybody done it? Yes.
General examination, pallor cannot be assessed.
Why pallor cannot be assessed? Yes, always remember when you are appearing in the examination, you must say if the patient is jaundice, you will not comment on pallor, because both the things cannot be seen simultaneously, especially if it is jaundice. So you will say that since the patient is jaundice, pallor cannot be assessed. Then
Icterus is present in upper bulbar conjunctiva and the palms of the patient. Cyanosis.
So it is moderate.
Moderate.
Mild is only in bulbar conjunctiva, moderate in the palms, and if it is all over the body, then it is severe. So it is a moderate type of jaundice, right? Okay, then?
Clubbing is absent. Lymphadenopathy is absent.
Clubbing and polynychia also you have to mention. Then?
Edema is absent.
Edema, which edema?
Pedal edema is absent.
Pedal edema, you have to see. You have to press here like 30 seconds. And on the shin also, there is some pitting edema. There is pitting, you see. So unless they do 30 seconds, you have to press on the shin or on the dorsum of the foot. So in this case, there is pitting edema. So there is definitely pedal edema. Any other finding? Lymphadenopathy. What lymph nodes you have examined? In this case, you have to examine the left supraclavicular lymph nodes. Of course, all the cervical lymph nodes have to be examined. from the submental, submandibular, preauricular, occipital, then jugulo-digastric, jugulo-humeroid, and supraclavicular. On both sides, jugulo-digastric, jugulo-humeroid, and supraclavicular. Then you have to also examine she has an amputation of the arm. This has to be examined and mentioned in the examination. So you can't skip the things. Similarly, there is axillary lymph nodes are not palpable on either side. So there is no lymphadenopathy in the neck, no lymphadenopathy in the axilla. Groin also, there is no lymphadenopathy. There is only pedialyma. So in the general and vitals, pulse, have you taken? Just take. And she has a cannula in place, and she appears to be febrile at this point of time. Actually, these are very important things, and you tend to rush to the abdominal examination unless and until you have a baseline clinical examination including history, general examination, and then you go to the systemic examination. So in this case, you have missed the general examination. One major part is she has an amputated limb, which, and this, and she says it is congenital. So since she was born, she is having this pathology. So that is very important. Plus, you have a cannula in place, and she, although she does not have very faces which are very sick, but still because of the cannula, that means she is having some acute illness also. So that is why she was admitted in the hospital and she is being treated. How much is the pulse?
81 beats per minute, regular, regular, normal volumic, no special characteristics.
Okay, so the pulse is normal. Blood pressure, of course, we have to check again. And she is afebrile, because if the pulse is 84, is unlikely to be a febrile patient. So with that, we come to the abdominal examination. And in the abdominal examination, as you can see, on inspection, there is fullness in the right and left flanks. On inspection, umbilicus appears to be a bit transversely stretched. There are no scar marks over the abdomen, and she is having normal respiration. No visible peristalsis, no visible pulsation. On palpation, there is no tenderness in the abdomen, and local temperature, if you compare it with the chest, is normal. So local temperature is not raised. Now, since she is jaundiced, the most likely area which needs to be examined is the hepatobiliary system, because in the history, from the history you know that she is jaundiced and she's got some epigastric discomfort. So whenever there is palpation, should concentrate on those areas where the pathology appears to be there. And in this case, since jaundice is there, it is 99% likely to be associated with hepatobiliary system. So we will come to that last. So before that, you do the general palpation of the abdomen, and you see the left iliac fossa, you see the suprapubic region, and you see the right iliac fossa, and then you gradually ascend up first on the left side, सांस लीजिए, to see the spleen. The spleen is not palpable. Costal margins are normal. Then now we come to the right side, and we ask her to take a deep breath, सांस लीजिए. And when she is taking a deep breath, my finger is striking some organ which in the right iliac fossa is likely to be the gallbladder. So, and the shape also is pyriform, which I can feel, and it is, if you raise the scale, so it is around 6 centimeters below the costal margin and 5 centimeters transversely. So it is oval in shape and it is non-tender. I am trying to press here, but she is not having any wincing. But there is a palpable gallbladder, and सांस लीजिए, and the costal margin, below the costal margin there is mild hepatomegaly. I can see around 1 centimeter, 1.5 centimeter below the costal margin, there is hepatomegaly on the right side, the left lobe does not appear to be enlarged. Only the right lobe is enlarged and it's going up to the anterior axillary line. So there is hepatomegaly and a gallbladder is palpable, which is 6 centimeter vertically and 5 centimeters transversely. It's non-tender and it is firm in consistency, right? And it is non-tender. So that is about the gallbladder. Now we like to see whether she's got any fluid in the abdomen. For that we will do the shifting dullness. It's all resonant. Dull slightly on this side. थोड़ा और करवट ले लीजिए उस तरफ. We wait for 1 to 2 minutes. Let the fluid shift if it is there on the opposite side, and then we do percussion again. Now it is resonant. ठीक है, सीधी हो जाइए, सीधी हो जाइए, पैर कपड़े ठीक कर लीजिए, इसको बांध लीजिए. Now let us summarize the case. We like to also do a PR examination in this case. Why PR examination? Because she says there is bleeding, black colored stool, and also any jaundice patient we have to confirm whether it's clay colored stool or not, or what is the nature of the stool. And if there is any pathology in that area, anorectum, maybe malignancy, maybe benign disease, which has to be examined. So no abdominal examination is complete without a PR examination. So to summarize this patient came to us yesterday, as she says, and she was having symptoms of jaundice, and she consulted a local practitioner in the village where she was given IV fluids, and she did not have any pain in the abdomen at that point of time. However, there was some discomfort in the epigastric region. For that, she came to the hospital, and on examination, we have found that she has got icterus, and she has no axillary lymph nodes. There is no cervical lymph nodes. There is mild pedal edema. On abdominal examination, on general examination, vitals are normal, and there is hepatomegaly, there is palpable gallbladder on the right side, and there is mild free fluid in the abdomen. So with this clinical presentation, we have to see what is the possible clinical diagnosis. So first of all, jaundice. So now we have to decide what type of jaundice is this. It's a jaundice obstructive or non-obstructive. So first of all, non-obstructive jaundice is associated with fever. In this case, there is no fever. It's usually associated with itching, no itching, and no clear stools. So, and melena also is in both. There is a possibility of melena because vitamin K is deficient, fat absorption is compromised, especially in obstructive jaundice, and that can lead to bleeding disorders. So that can initiate enema, bleeding per rectum. Now in this case, the jaundice is mild to moderate. I will say moderate because the palms are also palpable, having the jaundice. So she's got moderate jaundice and palpable gallbladder. So palpable gallbladder and hepatomegaly, non-tender. If it's a tender hepatomegaly, then usually it is hepatitis. That is a benign disease. But if it is non-tender and there is palpable gallbladder. So what are the causes of palpable gallbladder? Anybody? Of course, what is Coviser's law?
If in a patient of jaundice, we can palpate the gallbladder, it is not due to stones.
The corollary to this is that if the patient is jaundice and the gallbladder is palpable, it is not because of stones. That means it is not because of benign disease. So in this case, the patient has got a palpable gallbladder with jaundice. So it is likely to be a malignant disorder. Now, malignant disorder, most common is carcinoma head of pancreas. The second most common is periampullary carcinoma. Third is cholangiocarcinoma. And fourth is carcinoma gallbladder. Now, these are the four common conditions in which the patient will present like this, with a palpable gallbladder and with jaundice. So now we have to analyze from the history and examination which type of pathology is this. Is it carcinoma head of pancreas, is periampullary carcinoma, cholangiocarcinoma, or carcinoma gallbladder? Now, periampullary carcinoma, there is 10 to 20% chance of having waxing and waning type of jaundice. That means patient has jaundice and after some time it sloughs off and the jaundice wanes. But that is only possible in 20 to 30% cases. So even if it is not there, it can be periampullary carcinoma. Second is carcinoma head of pancreas, which is the most common. Why it is not carcinoma head of pancreas? Gallbladder is palpable, which is there in carcinoma head of pancreas, and patient is middle-aged. She is not having itching at that point of time, but in case of periampullary carcinoma and also carcinoma head of pancreas, the gallbladder is distended and has fluid which is fluctuant. In this case, it is the gallbladder is firm to hard in consistency. So because of the back pressure, the bile collects in the gallbladder and the gallbladder gets distended and becomes tense. So that finding is not there in this case on clinical examination. Hence, it is very unlikely to be because of carcinoma head of pancreas and periampullary carcinoma. Third is cholangiocarcinoma. So cholangiocarcinoma again, if it is at above the junction of the cystic duct to the CBD, then there will be no gallbladder palpable. If it is below that, gallbladder will be palpable. Again, the same features will be there. It will be tense and distended. But in this case, it is not tense and it is not distended. So again, it is unlikely to be below the cystic duct junction, or above that we cannot say with certainty, because that is Klatskin tumor, which is a different presentation. The gallbladder will not be palpable. In this case, the gallbladder is palpable. So by clinical assessment, we can say it is very unlikely to be cholangiocarcinoma, very unlikely to be carcinoma head of pancreas, and very unlikely to be periampullary carcinoma. So one important disease remains, that is carcinoma gallbladder. So it is firm, it is hard, and it is the only presentation in this case. So the most likely clinical diagnosis in this case is carcinoma gallbladder with jaundice. Now the question arises, is carcinoma gallbladder causes jaundice or not?
Late presentation.
What do you mean by late presentation?
Very late. Not early presentation.
Why there is obstructive jaundice in case of carcinoma gallbladder? Because the gallbladder will infiltrate the liver, but just infiltration of the liver will not cause obstructive jaundice. So in this particular case, the explanation is that the metastasis is at the porta hepatis, because the gallbladder spreads by all means, by local invasion, hematogenic spread, and also lymphatic spread. So hematogenic spread will cause metastasis in the liver and other organs like lungs and bones, etc. But lymphatic spread is to the porta hepatis, where the lymph nodes become large and they compress upon the CBD, leading to obstructive jaundice. So in this case, the most likely diagnosis is patient is having carcinoma of the gallbladder with metastasis at porta hepatis, leading to obstructive jaundice. So now what is the pathology and how you confirm the diagnosis? Anybody? You would like to do a liver function test. Direct, indirect, that will tell us whether it is obstructive jaundice or not. Serum bilirubin direct will be raised in a obstructive jaundice and indirect will be in a, so that is there. SGOT-PT will be near normal in, or maybe slightly raised. Then important thing is ultrasonography. So ultrasonography will definitely show where is the pathology. It is in the gallbladder. Of course, if it is in the pancreas, it's not very good investigation. But gallbladder pathology will be seen. What is the condition of the gallbladder? Whether they have metastasis at porta hepatis, and what is the other state of the gallbladder, and also free fluid in the abdomen. So in this case, there is free fluid in the abdomen, mild free fluid, and there is anemia also. So these are comorbid conditions. So now if you stage this, so investigation, CBC, that is hemoglobin, we like to know because she is anemic. Then we like to do liver function test to confirm what is the status of the liver, and direct or indirect. Then the third investigation is ultrasonography. That will tell us it is gallbladder pathology or pancreatic pathology or whatever. And then you have to go to CT scan. So CT scan will definitely tell us the primary pathology in the pancreas, if it is there or if it is not there. Also in the gallbladder, you can see what is the status of the gallbladder, which part of the gallbladder is involved, all the part or one part or fundus or the Hartmann's pouch, or where is the pathology. And also it will show the metastasis at porta hepatis, which is causing obstruction and leading to obstructive jaundice. So now the investigation starts with CBC, liver function test, ultrasonography and CT scan. So that will definitely tell us, then staging will be required in this case. But if you see presence of ascites, so if it is a malignant ascites, already stage 4. So it is basically in non-operable state as of now from the clinical assessment. However, radiological and CT examination will confirm the status and will tell us how to move forward. But supposing it is a case of obstructive jaundice only and it is non-operable, because stage 2 onwards, any major surgery is contraindicated in a carcinoma gallbladder. So the only thing which we can do is to relieve the obstructive jaundice. So for that, what is possible? You can do a endoscope, ERCP and stenting, and that will relieve the obstructive jaundice and you give palliation to this patient. Thank you very much. Thank you, sir.